So I will start with this lecture. This is me, Luis Alonso from Spain. Now is the 11:30 here in Spain, and I hope you can see my slides. And this is the topic: stereoscopy and retained products of conception. I have no financial relationship to disclose, and those are the objectives of this lecture. Identify the different patterns by stereoscopy and by ultrasound, select the best option for the treatment, for the management of this pathology, and especially, and this is very important for me, recognize life-threatening situations that can be related with this pathology. So when we talk about retained products, we can just focus in the definition is tissue that remains inside the uterus after a miscarriage, a planned pregnancy termination or delivery, or on the other hand, we can see like a complication. When there are some rest inside the uterus, we have a complication, and we have to look for the best treatment for that patient to cause no more problems. Okay, so it's something common that affects to 0.5% of surgical abortion in the first trimester, about 1% of third pregnancies, and up to 5% of cases of medical management of induced abortion. Okay, so in cases of medical management, as you can see there, the percentage of affected women is higher. There are some risk factors associated with this pathology. Acrotism of the placenta is when the placenta, you know, is hard attached in the myometrium. Second trimester demise, up to 40% of cases develop retained products, and uterine abnormalities. There's a prevalence of 10% in patients with these retained products. So this is the timeline about what it's the treatment and what we know about this. First case described in the literature was in 1884, a patient with rest inside the uterine cavity for 12 years. Then in 1984, Chavo was the first to use the stereoscope just to see where the problem was and remove with polyp furthers. Goldenberg, 1997, the first to use the stereoscope to remove that tissue using the loop without energy. And Smorgy presented the first meta-analysis with different studies. He saw low complication rates when we use the stereoscopic approach. Which are the symptoms of this pathology? The most common and the most important is uterine bleeding. Any bleeding heavier or longer than usual for more than 3-4 weeks after a pregnancy termination can be related with this pathology. Can be found fever, pain, uterine tenderness, infertility, but remember that bleeding after the termination. And the diagnosis is based, as you can see there, in different medical history, laboratory, ultrasound. I have made a tick in some of them, especially in the ultrasound and in the stereoscopy. So for me, ultrasound is very important, this pathology. And some years ago, we described 4 different types, 4 different patterns of ultrasonography in the case of retained products. What we call type 0 is an hyperechogenic vascular mass in white color. Type 1 is a vascular or low vascular mass. Type 2 is highly vascular mass inside the uterus, but with normal myometrium. And type 3 is highly vascular mass inside the uterus, but also the myometrium is highly vascularized. Those are the patterns. And this is a short video in which you can see a type 2 with that high vascularity of the myometrium. This is important because if we look inside the uterine cavity, there is a correlation with the ultrasound and the hysteroscopy. So in type 0, what we see is a white mass with no identifiable structures. Type 1, we can see the chorionic villi in white or pale color. Type 2, we can see the chorionic villi in dark or red color. And type 3, we can see aneurysm, big vessel, even arteriovenous malformation in the implantation area. Those are the patterns. And look at this small video, and you can see that pushing arteriovenous malformation. Okay, if we touch this with our curette, we can have big problems. Okay, so try to go to the next slide, in which we're talking about the treatments. We can have a expectant management, medical treatment, curettage, or hysteroscopy. Okay, the first should be probably the expectant management. This should be the first option, and because sometimes solve the problem, most of the time solve the problem with a success over 94% at 2 weeks. And because, by the other hand, sometimes facilitate the surgery, because delaying the surgical timing could be an approach because reduce the intra-retained products blood flow. In the medical treatment, we can use misoprostol or methotrexate. It's an effective in some more of 90% of cases. And let's talk about the surgery. The most commonly used is the curettage. But the problem of the curettage is that 1 in 5 women will have more tissue or still have some tissue inside the uterus after the curettage. 40% of women with repeated evacuation will develop intrauterine adhesions. And there is a low rate, less than 5% of cases of uterine perforation. But 40% in repeated evacuation will develop intrauterine adhesions. Regarding the hysteroscopy, the hysteroscopy is the best approach to remove this pathology. We will not have no adhesions, we'll have no the risk of left any tissue inside the uterine cavity, and we have like different stages in the treatment. First, we have to clean the cavity to remove all the blood and the clots that are inside, have a clear vision. Second, identify the implantation area. Think that this is a focal pathology. Retained products are located in one part of the uterine cavity, so we have to look for the implantation area. And third, test the grade of attachment. What I mean? I mean that sometimes when we find that tissue, if we push that area, the tissue is slightly attached, so it can be easily removed. We can use biopsy grasper, we can use scissors, we can use the cold loop as accurate without energy, we can use morthorated, whatever, because it's not hard attached. But sometimes the tissue is strongly attached. So we have to remove that tissue, probably in most of the cases, with the use of mechanical, maybe morthorators or electrical energy. In those cases, we don't have big vessels in the attachment area. But look, this is something similar to a fibroid, a myoma. But sometimes, look at here, the tissue is really strongly attached. And we can find Dorpis vessel. That's an aneurysm. This is a 26 French resectoscope of a normal roller ball, so it's a big vessel that will have some bleeding. Those are the cases in which we need to use electrosurgery to coagulate that area. And those are the cases that can be life-threatening for the patient. Okay, so I have here a small video in which we have the different parts of this first remotion of the blood and clots to have a clear vision, have to remove all that tissue that sometimes we can see properly inside the uterine cavity. Then we have to identify the implantation area of that tissue. Remember that this is a focal process, so we can see perfectly that the tissue is attached to the left uterine wall. Okay, and that area, look there, that's the implantation area. I have only 2 minutes, so selective coagulation of the vascular structures. Now here we're talking about type 3. Okay, and we have to coagulate the area and to remove the tissue, you know, because we have sometimes big bleeding. We can use the coagulation with the loop or with the ball. And then pushing, we remove all the tissue. Okay, so which are the advantages of this treatment? Those that you can see there. Minimal injury to the endometrium when we treat by hysteroscopy to the healthy endometrium. Low rates of intrauterine adhesions. I would say we have no adhesions. Complete removal, we see what we remove, so we have complete removal. We can identify if there is any uterine anomaly associated, and we have low perforation rates. So in conclusion, hysteroscopic removal of retained trophoblastic tissue is a simple, is safe, and is efficient procedure. There are different patterns that can be seen by hysteroscopy or by ultrasound. We have to know them, and those cases with highly vascularized myometrium can be life-threatening. Please be careful with the treatment of that pathology. So next time you face with a patient with retained products, think about the possibility of treating with the hysteroscopy or the resectoscope is something easy that you can do. That's all. Thank you. I think I was on time.